So chapter 6 is talking about nursing care of patients with fluid, electrolyte, and acid-base imbalance. And on this chapter, it has some information um, as for intracellular, extracellular. What do those terms mean? Intracellular and extracellular.
Intracellular is within the cells and extracellular is outside of the cells.
Definitely. When it talks about intravascular, what do that term mean?
Inside the veins.
Correct. Yep. And it talks about control of fluid balance. There are things that can affect fluid balance. We have hormones in our body that can affect fluid balance, where it's talking about the antidiuretic hormone. What is an antidiuretic hormone? What do that do? Because when I think about the antidiuretic, anti means no. When I think about diuretic or whatever, diuretic, it's flushing my system. It's flushing my system, making me urinate, that type of thing. So anti-diuretic is no urination. It's stopping it. So if an individual, just to say, has an increase in the ADH in the as for the antidiuretic hormone, if I have an increase in the antidiuretic hormone, what clinical manifestations do you expect to see as a nurse or a student nurse? What do you expect to see?
Kidney failure.
Well, why you say kidney failure?
Then you say no production of urine.
Yeah. A diuretic makes us urinate. Antidiuretic, we know that means no or stop. So that's stopping urination. What clinical manifestations will you expect to see as a nurse? Your patient is not able to urinate. What do I expect to see as a nurse?
Edema.
Swelling.
Swelling.
That's a clinical manifestation. I expect that edema, which is swelling. I expect the possibility of even hearing fluid in my patient lungs where fluid is starting to bag up. You may even see changes in your patient's skin color because they're not able to make urine or they're not able to produce urine or whatever, because we know the antidiuretic hormone, it is stopping urination and it's causing the individual to retain fluids. A diuretic, what is a diuretic going to do?
Help remove fluid.
It's going to help remove fluid. So that diuretic is going to cause me to urinate, that type of thing. What am I at risk for if I am experiencing polyuria? What am I at risk for?
Dehydration.
Possibly dehydration. Hey, you are urinating a lot. I need you to drink some fluids if it's acceptable. I need you to drink some fluids if it's not contraindicated. That type of thing. Patient may be at risk for fluid volume deficit. Is fluid volume deficit, is patient at risk for that?
Yes.
Hypovolemia.
Yes.
Hypovolemia, is a patient at risk for hypovolemia?
Yes.
Yeah, what is hypovolemia? What is hypovolemia? So I hear the word hypo. Hypo means something is low. Volemia is what?
Blood volume.
There you go. Well, you want to break down all of these words that y'all are going over. Make sure y'all are breaking all these words down to make this information make sense. And And it's talking about fluid gains and fluid loss. And it tells you people can survive without food for several weeks. They can survive only a few days without water. But we have to have fluid to survive. We can only go a few days without fluid to actually survive. And it talks about an adult loses as much as 2,500 mLs of sensible and insensible fluid each day. How would 2,500 mLs look? How do an ml look? How do an ml look?
A drop.
A drop. Nothing but a drop. There you go. How do 30 mLs look?
Isn't it? It'll be like 30 drops, a teaspoon, a tablespoon.
30 drops is correct. And that'll be 2 tablespoons. And it also will be 30 drops is equivalent to 1 ounce. 30 mLs is 1 ounce. But it's just to make sure that you all can picture these measurements. Because once you're able to picture these measurements, it all make sense. That's what's gonna make all this information make sense to you all. So with insensible and sensible fluid loss, it talks about sensible fluid loss is where we actually aware. So what is something that you would consider sensible fluid loss?
Sweat.
So yeah, we can say sweat definitely. What is sensible fluid loss?
Urination.
Yeah. And I would say sweat is a little iffy. Insensible fluid loss is where we don't even recognize it's occurring. So typically when we are breathing, we are losing fluids. When we exhaling, we losing fluids, that type of thing. It's something that you just don't recognize. So sensible, you recognize it. Insensible, you don't recognize it. Who would you say is at higher risk for dehydration? Who is at high risk for dehydration?
Elderly people, children.
Yeah, the elderly, children, people who are confused, that type of thing, are at risk for dehydration. Some of our people who are debilitated, disabled, are at risk for dehydration. And this is just talking about dehydration. What is dehydration to you all?
Like when you don't have no fluids.
Yeah, it's not enough fluids in your body. And it talks about the pathophysiology and etiology. Somebody tell us what pathophysiology means. What is pathophysiology? Because in this course, I will test you all on these terms. So I definitely did flip up some questions to test you all on these terms to ensure that you do understand what pathophysiology means and that you do understand what etiology means. And patho itself means disease. Physiology means how do it function. Patho is disease. Physiology is how do it function. So when the physician tell you, hey, you have diabetes, we want type 2 diabetes, you want to know the pathophysiology. Pathophysiology is where a nurse can just pretty much look at you and say, I know exactly what that disease is doing inside your body. That's the pathophysiology. I know how this disease functions. Etiology is the cause. What is the cause? What are the causes? That's etiology. Etiology is another word for cause.
I always get those two kind of mixed up. So can I give you an example just to make sure I have it in my mental correct?
Yes.
So for etiology, say for instance, someone diet they have they put too much sodium, too much salt in their meals when they're cooking. Etiology would be like for if they got, I guess, high blood pressure. Would that be etiology? Would that be the cause? The
That would
high sodium diet caused them to have high blood pressure?
correct. Yeah.
Okay. And patho is basically what the high blood pressure is doing to your body.
Yeah. What it's doing inside your body.
Okay.
Yeah. That's correct.
Okay.
At this point with your education, you all need to start looking at these diseases that you learn about, and it needs to be to a point where you all can picture everything that's occurring in your patient body, where you can picture, I can picture everything that's occurring inside of your body. Okay. And dehydration is the result of fluid loss. Whatever then caused the fluid loss is the result of fluid loss. And I'll tell you some of the common causes of dehydration and etiology of dehydration. Diarrhea can cause dehydration. Diuretic therapy, because I told you all them diuretics. You know, we had diuretic medications where them diuretics is flushing your system. It is flushing your system, causing you to urinate, that type of thing. Abscess, fistulas, hemorrhage, where you are losing copious amounts of blood, that is hemorrhage, that contributes to dehydration. The patient who's telling you, nurse, I've been throwing up all night I've been vomiting. Your patient who got tuberculosis, who is in the bed, sweating profusely, that um, these different conditions, these different things contributes to dehydration. It can result into dehydration. And as a nurse, once you realize your patient is at risk for dehydration based on your observation, this patient had diarrhea 6 times on my shift, interventions need to be put into place. Hey, Ms. Rogers. Hey, I recognizing you have diarrhea. I recognize wherever you want to encourage fluids. You want to encourage fluids to prevent the patient from becoming dehydrated. And that's how you prevent dehydration, is once you realize the patient is at risk for it, that you coming up with these different interventions.
I did. I got you up when I first started class. You said okay. And you went back to sleep.
And it talks about signs and symptoms of dehydration. Please press mute or I'm going to put
Rebecca, mute yourself.
The symptoms of dehydration. What do you expect to see clinically in a dehydrated patient? What do you expect to see clinically in a dehydrated patient?
Dry skin.
Dry skin is possible, yes. That patient lost fluid.
Altered mental status.
Dehydration, especially if it's severe dehydration, it can affect the person's mental status. What do they mean when they say poor skin turgor?
The tenting doesn't retract
Yeah,
within reasonable timing.
yeah. Well, I done pinched over your sternum, and that pinch left an indentation. It remained for a few seconds. That's a sign of dehydration. What color would your urine be if you are dehydrated?
Dark yellow.
Dark amber color. You need to go drink some fluid to go on to make your urine look pale yellow. You know, that type of thing. Because we know that dark amber, that's not considered a normal urine color. That is a sign of dehydration. So we know the urine will be darker. If the individual is dehydrated, is it going to contribute to fluid volume deficit or fluid overload?
Deficit.
It's going to contribute to a deficit. So that also will result in hypovolemia. or low blood pressure. What about the temperature? You are dehydrated. What would your temperature be? Will you have a subnormal temperature or not?
No, would it be high?
Yes. Tell me why your temperature would be high.
Because you don't have any fluid cooling it off.
There you go.
Yeah, your body can't.
So all the time when y'all patients or when y'all grandma or the babies got fever, are we gonna always think infection?
No.
No, we're not. Because we are student nurses, we are nurses. And we know for a fact when patients are experiencing fever, hey, this patient can be dehydrated. That can be the reason this patient have a fever, or it can be to the point the patient have an infection. This patient may have a systematic infection. That's the reason this patient has a fever. So dehydration can result in a fever. Then it just talks about complications of dehydration, how if you are dehydrated and you don't have a sufficient amount of blood volume, how it can result into organ failure and ultimately result in death.
Clean up the basement. I did already. Okay.
Please press mute.
Sorry about that. Thank you.
Yeah. And it just talks about some diagnostic a test where a patient who is experiencing dehydration, or even a patient who we suspect that's dehydrated, well, we do want to look at the BUN. The BUN, the blood urea nitrogen level, is something that we actually should look at, because that actually, BUN can let you know about kidney function, but it also can let you know if a patient is dehydrated. Patients who are dehydrated will have a high BUN. So whenever I think about BUN, I always think with BUN, if it's high, you dry. If BUN is high, you are dry. So if your blood urea nitrogen is elevated, you are dehydrated. It's a sign of dehydration. It can be a sign of dehydration. It also can be a sign of kidney failure. But typically, if with your BUN, if you high, you dry. So you always want to think dehydration. If your BUN is low, what would that make you think? Come on, y'all.
You said if it's low.
Critically think. I just told you if your BUN is high, I'm going to think dehydration. So if your BUN is low, what are you going to think?
You have too much fluid.
Too much
Excess
fluid
fluid.
overload.
Definitely. I may think fluid overload. You have too much fluid in you. That's why your BUN is low. But we know when your BUN is high, we want to think high and dry. And for the patient who is dehydrated, if they are hospitalized, the patient will be placed on IV therapy where they are receiving isotonic fluids. And the isotonic fluids is kind of like fluids that has the same osmolarity as human blood, and which is like normal saline. It has the same osmolarity as human blood. So a patient who's dehydrated, they definitely going to get put on fluids. We're going to encourage fluids, that type of thing. What are some concerns for the patient who's dehydrated? Hello?
Kidney failure.
Yeah, kidney failure. So if you're thinking kidney failure, what is something that you need to be monitoring as a nurse?
Fluid levels.
Yeah. So what are fluid levels? What fluid levels will you monitor?
Their output?
Output.
There you go. Yes, I want to monitor your urinary output. Every time you urine, I want you to urinate in this urinal, or I want you to use this bedpan so that we can measure it to make sure you are urinating the appropriate amount. What is the bare minimum urine that the human body should be making in an hour?
30 minutes.
30 ml of urine. So for an hour, we know it's normal for the kidneys to produce 30 to 50 ml of urine an hour. And it also just talks about a loss of 1 or 2 pounds or more per day may suggest water loss. And also, your patients who are dehydrated, we want to monitor their weight. We want to monitor their urinary output. We also want to monitor their intake. We want to monitor what you're taking in, because what you're taking in is what should be coming out. And then it tells you right here again where I announced you all, our confused patients are at risk for dehydration, because if I'm confused, I barely know if it's hot or cold outside. Nevertheless, I barely know if I'm thirsty or not. So we should be encouraging fluids. Ms. Rogers, hey, drink some water. Drink some water. I've seen you dancing with activities today. Have some water. You don't like water, Ms. Rogers? How about some orange juice or some apple juice, Ms. Rogers? Where we are encouraging them to drink fluids. And it just talks about cultural considerations. Will somebody read cultural considerations? Because what you all need to be clear is every culture is different. Some people have cultural practices that may contribute to dehydration. Will somebody read that paragraph?
Muslims who celebrate Ramadan traditionally fast for 1 month from sunup to sundown. Although the ill are not required to fast. Is that adherence?
Yes.
Adherence.
You said that was adherence?
Yeah, adherence.
Who are ill may still wish to do so. Fasting may include not taking fluids and medications during daylight hours. For a Muslim who is ill and is fasting, the nurse may need to alter times for medication administrations, including intramuscular medication. Special precautions may need to be taken to prevent dehydration.
So next is talking about fluid excess. Give me another word for fluid excess. Give me another word for fluid excess.
Overload.
What's overload? Fluid overload. Give me another word for fluid excess and fluid volume overload.
Hypertonic?
Mm-mm.
No.
Are you saying like the medical term?
Hypervolemia.
Hypovolemia is another word for fluid volume excess, fluid volume overload. You want to make sure y'all know that some of these terms are interchangeable. There are interchangeable terms. So fluid volume excess. Somebody walk us through the pathophysiology of fluid volume excess. Walk us through the pathophysiology of fluid volume excess. Okay. So fluid volume excess, we definitely know that at some point something is causing the body to retain too much fluid. Something is contributing to too much fluid in the body. And where too much fluid is in the body, where a patient is hypervolemic, is it to the point that this patient isn't able to urinate, patient isn't able to make urine? So that means that all this fluid will begin bagging up in the body. And if all this fluid is bagging up in the body, we know that we will see clinical manifestations of fluid volume excess. And a clinical manifestation can be, hey, I see edema. This patient is edematous, that type of thing, where I'm seeing the swelling. I'm listening to the patient lung sounds. I hear fluid in the patient lungs, that type of thing. And fluid volume excess can cause multiple clinical manifestations. What type of therapy will a patient require who is experiencing fluid volume excess? What type of therapy would they require?
Respiratory.
But they might need some type of respiratory therapy. But what are you thinking? What med can we get this patient?
IV
Diuretic.
therapy.
Diuretics.
There you go. We need to get that patient a diuretic. That patient will be started on a diuretic. If you have too much fluid in your body, you are in fluid volume excess, physician will order a diuretic. And typically that diuretic is Lasix. That would be the medication the physician typically order for rosemide, Lasix, that type of thing, that will cause the patient to have to urinate a lot to remove the fluid, to remove that excess fluid. And it just talks about some of the signs and symptoms of fluid volume excess, in which I just communicated about it. One of them is edema. It talks about dyspnea. Why would dyspnea be a sign and symptom of fluid volume deficit? Huh? Why would dyspnea be a sign of fluid volume excess? What is occurring to cause that? What do dyspnea mean?
Difficulty.
Shortness of breath.
Yeah, difficulty with breathing, shortness of breath, that type of thing. So what's causing that?
The fluid backing up in the lungs.
Literally, you have fluid in your lungs. So if y'all have fluid in your lungs, at some point you can't breathe right. And then it talks about crackles in the lungs. What is causing crackles in the lungs? What's causing crackles in the lungs?
Isn't that like when it's a buildup of fluid?
Yeah, crackles come from fluid. When you hearing crackles, that means that, hey, you got some fluid up in these lungs. And anything abnormal when you are dealing with these patients, any new clinical manifestation, any worsening of condition, as a nurse, you need to be reporting that to the physician. When you have your CNAs and your patient care techs who work for you, they should be reporting changes in conditions to you. And as a nurse, we report changes in conditions to the physician. So that's what we're supposed to do as nurses. When we recognize something is going wrong with a patient, you need to be notifying the physician. And if the patient have a guardian, you need to be notifying the guardian too. Because that's part of the reason some of these guardians be ready to sue. When they find out, my mama been in your hospital or nursing home for this amount of time. Y'all didn't tell me my mama was getting worse. Y'all didn't tell me my mama was about to die. And they ready to sue you. that type of thing. So you have to notify patients' guardians when they have changes in conditions, as well as the physician. Physician need to be notified. And again, as nurses, our CNAs and our patient care techs are eyes for us. And as nurses, we are the eyes for the physician. And it just tells you diagnostic tests that with fluid volume excess, the BUN will be decreased. The patient BUN will be decreased. The hematocrit will be decreased. When you had a whole lot of fluid in your body, all that excess fluid, it can cause a decrease in a lot of levels, because it's pretty much like you had too much water. Because just to say, what could I make an example of? Just to say, if you had poured sugar in a cup or whatever, it's easy for you to take a spoon and just pretty much get the sugar out the cup. But if you pour sugar in a cup, the same amount of sugar, and then you poured a whole bunch of water in it, you're not about to get the same amount of sugar that you just got when it was no fluid in it. So once fluid got in it, it kind of decreased the amount of sugar that you can scoop up out that cup. So fluid volume excess will result in a lot of lab values being decreased. A lot of the lab values will be decreased with fluid volume excess. But if you have no fluid in your body, a lot of those lab values will be elevated. And sometimes it's a false elevation due to the fact that you are dehydrated. It's looking like everything is high, but it's not that it's really high. It's just that you are dehydrated and you need some fluid so everything else can go back to its normal level. And it talks about urine specific gravity, but we will talk a little bit more about that. But the same thing with BUN. With BUN, if you high, you dry. That's the same thing for urine specific gravity, which is the lab value. And with that, if you high, you dry as well. And a lot of things, if you all know, hey, if this is high, this is what this means. So it also should help you realize if it's low, then typically it could be the opposite of this. In patients who are dehydrated, they may need to be repositioned with the head of their bed elevated, because when you're dealing with patients who are having difficulty with breathing and not dehydrated, patients who are in fluid volume excess, you're dealing with a patient who's having difficulty in breathing, we want to put them in semi-Fowler's or high Fowler's position. When you are dealing with patients where fluid volume excess has resulted in difficulty with breathing, we might need to put them on oxygen therapy so that we can ensure adequate tissue perfusion, which will prevent organ failure. And it's just talking about drug therapy, where again, I told you all, if a patient is experiencing fluid volume excess, physician will start the patient on Lasix, furosemide, and what being started on furosemide, the purpose of the patient being started on it is because we want you to urinate. We want to contribute to fluid loss. And loop diuretics, because furosemide is a loop diuretic, it will cause the kidneys to excrete sodium and water. And it also tells you potassium is lost, and potassium is critical. So when a patient is on Lasix, we should be monitoring their potassium level. We should be monitoring a potassium level because we know that diuretic, that particular diuretic will cause a patient to lose potassium. In any event, we know a patient is at risk for losing potassium. We do want to encourage them, hey, we want you to eat foods, if it's not contraindicated, that is high in potassium, or we want you to take potassium supplements. But typically, before we start with anything pharmacological, we want to start with non-pharmacological interventions. So if I know my patient is at risk for decreased potassium levels, we want to start with non-pharmacological interventions, and that would be me encouraging them to eat foods. You need to eat foods high in potassium. And diet therapy, it's talking about diet therapy. What is the concern with sodium? What concern do we have with sodium? What does sodium do to the body?
Raise your blood pressure.
It can raise your blood pressure.
It holds in the fluid.
It causes the individual to retain fluid. So a patient who is experiencing fluid volume excess, should they be placed on sodium restrictions?
Yes.
Tell me why.
Yeah.
Well, what you all need to know, where sodium go, where sodium go, water follows. So if I put sodium in my body, and sodium, another word for salt to me, if I put that in my body, that means that I'm about to retain fluid as well. Where sodium go, water follows. If you put sodium in the body, you're going to retain fluid, but also to kind of help get rid of sodium, you can tell your patients to increase their potassium. Potassium do help an individual to rid itself of sodium or excrete sodium. But some of the concerns is you all need to make sure you know when you are dealing with patients who are at risk for fluid overload or who is experiencing fluid overload, they need to be educated about lowering their sodium intake, or they need to be educated if they are placed on sodium restrictions. And what is pitting edema? What is pitting edema?
Does it have something to do with how deep the swelling is?
Yeah. So we're pitting edema. If I put, just to say, if your ankles or something are swole, and I take my fingers, I press into your ankle, and it left some type of indentation, that would be considered pitting edema. It left an indentation. And this right here actually give you a list of foods that are high in sodium. I told the students who I had for fundamentals of nursing, too, why it is important that you all need to start reading nutritional labels. When y'all are going to the market, you buying foods, or even a store, gas station, you buying foods that you all know you like, you need to be reading those nutritional labels to make sure you understand what is in what. Your bag of potato chips, what nutrients, what vitamins are these chips high in, so you can understand it. Is it high in trans fat, that bad fat? Is it high in saturated fat, that bad fat? Is it high in sodium? When I know I'm trying to lose weight, and part of me being able to lose some weight is decreasing my sodium, because I know if I'm consuming foods high in sodium, that's going to contribute to me retaining water. That's going to contribute to me retaining fluids or whatever. So make sure at this point that you are going to these markets and these gas stations and these stores, and you are reading those nutritional labels to understand what is what. So it actually give you a list of things that are high in sodium. So even as a nurse, if your patient is on fluid or sodium restrictions, if dietary then sent them up 2 packs of salt for they spaghetti and meatballs, you need to be removing that off their tray. Hey, you can't have this. You on sodium restriction. But of course, patients do have rights. They do have a right to say, well, I don't care about being on sodium restrictions. I still want my salt, and you don't got to give me my salt. I'm gonna have my daughter to come up here and bring me some anyway. That type of thing. Some patients are non-compliant with their care plan, and they have a right to be. But what we do as nurses, we're gonna make sure we document on you. Because if you drop dead, you're not finna have an opportunity to feel that you about to sue us. We're gonna document on you. Patient is non-compliant with plan and care. So you all need to know what foods are high in salt, what foods are high in potassium, that type of thing. And please don't forget, every hour on the hour, you need to put your name in the chat and put the time. So at 10 a.m., make sure that you put your information in the chat. That's how attendance will be recorded based on you all attending the Zoom meetings. And it show you a list of foods that are high in potassium. We know oranges and bananas have high levels of potassium. Potatoes, potato chips, high in potassium. Will somebody read this paragraph?
At times, a patient may experience problems because of too much or too little of an electrolyte. In general, if a patient experiences a deficit of an electrolyte, the electrolyte is replaced either orally or intravenously. If the patient experiences an excess of an electrolyte, treatment focuses on getting rid of the excess, often via the kidney. The underlying cause of the imbalance must be treated. The most important aspects of nursing care are preventing and assessing electrolyte imbalances. You must be vigilant in watching for signs of imbalance in high-risk patients. Serum electrolytes are measured on a regular basis. As a general rule, patients should be checked for electrolyte imbalance when there is a change in their mental status, either increased irritability or decreased responsiveness, or whatever muscle function changes. Patient education is another important nursing role.
Thank you. When it talks about hyponatremia, what do hyponatremia mean?
Low sodium.
Yes. So we about to talk about some of the electrolytes. Hyponatremia, you all need to know the normal range for sodium. What is the normal range for blood serum? For serum sodium. What is the normal range for sodium?
135 to 145.
Awesome. Who's that? Miss Carter. Awesome. Yes. The normal range is 135 to 145. Anything below or anything above those numbers, we definitely know isn't considered normal. And hyponatremia, we know that is low sodium, low blood sodium. You have low sodium. And it talks about some of the things that put patients at risk for hyponatremia, such as being NPO, nothing but mouth, individual who is experiencing excessive diaphoresis, Diuretic therapy can contribute to the loss of sodium, electrolyte imbalance, that type of thing. And it just talks about what hyponatremia, some of the elderly population can experience confusion from it. So hyponatremia, would that contribute to fluid volume deficit or fluid volume excess? Hyponatremia, will it contribute to fluid volume deficit or fluid volume excess?
Would it be
Deficit.
deficit?
Deficit, yes, it will contribute to fluid volume deficit. If you don't have a lot of salt, that means you don't have a lot of fluid in your body. Or if you don't have high sodium, you don't have high fluid levels. Hypernatremia. What is hypernatremia?
High
High
sodium.
sodium.
High sodium. And just a quick question, with hyponatremia, what might be some therapeutic measures? What do you expect the physician to do for a patient who's hyponatremic?
To add salt, add sodium, maybe through IV.
Yeah, the physician is putting that patient on IV fluids. You need to be placed on IV fluids. Will sodium be restricted for this patient?
No.
Of course. And hypernatremia is fluid volume excess. And not fluid volume, it can result in fluid volume excess. We know hypernatremia, individual has high sodium levels. Individual has high sodium levels. And this just talks about the signs and symptoms of hypernatremia. Will somebody read signs and symptoms?
It's usually one of the first symptoms to appear. If you eat salty foods such as potato chips, the amount of sodium in your body increases and you become thirsty. Other signs and symptoms of hyponatremia are vague and non-specific until severe excess is present. Like the patients with a sodium deficit, the patients experiencing sodium excess has a mental status change, such as agitation, confusion, and personality changes. However, this time the cause is too little fluid in the brain tissues. Seizures may also occur. At first, muscle twitches and unusual contractions may be present. Later, skeletal muscle weakness occurs that can lead to respiratory failure if it affects the diaphragm. A fluid deficit or fluid excess accompanies the hypernatremic state. The patient also has signs and symptoms associated with these imbalances.
Mm-hmm. And then it talks about potassium imbalance, hypokalemia, and hypercalemia. What do hyper and hypokalemia mean?
Higher low potassium.
Correct. Hypokalemia, potassium deficit, hyperkalemia, potassium excess. Potassium is critical due to the fact that it can cause heart failure. It can actually stop your heart if your potassium level falls too low, or if your potassium level is high. It can result in heart failure. It can cardiac arrest. It can stop your heart. So that's what the potassium can do, and that's the reason why potassium is so critical. If it's low or if it's high, it's critical that it's reported to the physician. But any abnormal lab need to be reported to the physician, but some things are considered critical. What are some things that can contribute to hypokalemia? What can contribute to hypokalemia? What contributes?
With deficit,
Like diarrhea and vomiting.
yeah, losing a lot of fluid.
Diarrhea, but I want you to be specific. we're losing a lot of fluid. What's causing the loss of fluid? Vomiting, diarrhea can contribute to hypokalemia. We just talked about a medication that can contribute to hypokalemia. What is that medication called?
Diuretic.
Lasix.
The medication
Lasix.
is called Lasix. All diuretics don't contribute to potassium loss, but some do. And we do know one of the diuretics that contributes to potassium loss is what we just said, excuse me, is Lasix. And sometimes the patients do have low potassium. They can say, hey, I'm feeling cramps, feeling muscle fatigue. Some of them can even feel arrhythmias or whatever, and that is an irregular heartbeat, and that can be life-threatening. It can lead to cardiac arrest. So again, it's critical when your patient's potassium level is falling below normal range or going above normal range, that is reported to the physician. What is the normal range for potassium? What is the normal range for potassium?
3.5.
3.5 to 5.
0.3.
5. It's 3.5 to 5. But you all will learn once y'all go to different clinical sites, you get your jobs. Some places, they numbers may be off just a little bit. Maybe they normal potassium 3.5 to 5.3, that type of thing. So some stuff could be a little off, but overall, you still want to understand the ranges. And with hyperkalemia, can kidney failure contribute to hyperkalemia?
Yes.
It can. Because if your kidneys fail, you're not able to rid all of the potassium, so kidney failure can contribute to hyperkalemia. And just the FYI, for a patient who is experiencing hypokalemia, physician will get a patient potassium by IV. Typically, patients get potassium by IV to help bring up their potassium levels. Some patients, the doctor will order a pill by mouth to help bring up the potassium levels. The patients who do get potassium by IV, their complaint is how it just burns. Oh my gosh, it just burns, it hurts. That type of thing when they get it by IV. And with hyperkalemia, patient receives too much, has too much potassium in their body. You know, individuals can have too much potassium in their body as a result of IV therapy or taking different supplements, over-the-counter supplements, can result in hyperkalemia. It's also a such thing of potassium sparing diuretics, where it talks about it right here. Potassium sparing diuretics. Aldactone is a potassium sparing diuretic appeal, that type of thing. Aldactone that can contribute to potassium retention, where the body is retaining potassium, and aldactone is a diuretic. It's a diuretic, so we know that it will make you urinate a lot, but it's potassium sparing. It makes you hold on to potassium. So if a patient is on this medication, I want to monitor their potassium level. That's what I'm going to do. Let's monitor your potassium level to make sure you aren't retaining. And hyperkalemia can result in increased GI motility. And what would increased GI motility result in? What would increased GI motility result in? Hello? What would increase GI motility result in?
Like
Hypo,
So that's nothing but saying if you got a lot of movement in your GI tract, what's that's gonna result in? Probably make me have to poop a lot more. Do that make sense?
yes.
Yes.
So increased GI motility will result in diarrhea, that type of thing. Decreased GI motility, what would that result in?
constipation.
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 Yes. What would I need to point out? So your patient who is experiencing hyperkalemia, you have an excess amount of potassium, or you hyperkalemic. Therapeutic measures would be, of course, we want to limit potassium-rich foods. We want to limit potassium-rich foods. Excuse me. Please press mute. And in the future, we'll come to a point if your conversation is disturbing the class, where I would just put you in a waiting room. I will put you out the class. You'll be put out the class. So I would take it today would be the first day where I would consider it a warning and moving forward. I would not say excuse me or anything. I would just move you out the class and you'll be out for that day. With therapeutic measures, when your patient is hyperkalemic, hyperkalemia, physician will order sodium K-exalate. Patient will be placed on, will take K-exalate, and the K-exalate helps to get rid of the excess potassium, and typically it causes the patient to poop. And it's a polystyrene sulfonate, where the physician will place the patient on that. It's also called K-exalate. Patient will be placed on that, cause them to poop to get the excess potassium out. And it talks about calcium imbalances, where we definitely know calcium has an impact on the individual bones as well as their teeth. We need to know the normal range for serum calcium. And it talks about hypokalemia, where we know hypocalcemia. Hypocalcemia is low calcium. It's low calcium. And we know that low calcium can result in osteoporosis. And that's the deterioration of the bones, that type of thing. So low calcium can result in osteoporosis. And with osteoporosis, that is a whole disease process where some races are more prone to it at earlier ages than others. And the races that I kind of look at and say, hey, they more so prone to osteoporosis are the races where they are more so, they have smaller bones. When I think of the Asians, I think of, some of the Caucasians, they have smaller bones. So they are at higher risk for osteoporosis at earlier ages. African American, Mexican American, them type of things, them type of races have bigger bones. So their risk for osteoporosis isn't as high as Caucasian American or Asian American. And with osteoporosis, once you all become actual nurses, you all have to do CPR on patients. Some of the elderly population, you will be able to say, ooh, I think this patient probably got a diagnosis of osteoporosis. Because it was a patient, when I worked at St. John Hospital, I had to do CPR on her. She was actually another nurse patient, but the other nurse was kind of moving slow. I ended up initiating CPR on this patient. And when I initiated CPR on this patient, it was to a point where I felt her bones just crumble up. As I'm pressing into her chest, her bones was just breaking. And it was breaking so easy. And they were crumbling. It felt like a real hard piece of bread just breaking up or whatever. And one of my thoughts while I was doing CPR, I'm like, I wonder if she got like osteoporosis. I'm like, this is a real bad version of osteoporosis here. But I ended up looking her up, and she actually had a severe version of osteoporosis. She was a Caucasian woman, but it felt so disgusting to just feel somebody's bones just crumbling up when you are pressing in their chest. So when you all do CPR, the patients are at risk for broken bones. They are at risk for getting their bones broke. But hypocalcemia, of course, it can contribute to osteoporosis. Hypocalcemia patient has low calcium. We want to encourage them to take calcium supplements. We want to encourage them to increase consuming calcium-rich foods, that type of thing to raise the calcium level. If we actually suspect that a patient is hypocalcemic or experiencing hypocalcemia, we can do a Trouser Test or a Bostic Test. And we talked about this for you who all had me for fundamentals of nursing too, the Bostic Test and the Trouser Test. Does somebody want to explain this? So I said this picture is confusing me because the Bostic Test is the cheek and Trouser Test. Oh, okay, so this is right. I looked at the picture wrong. I'm like, it almost confused me. Trouser Test is where a blood pressure cuff is placed around an individual arm, and you would typically use the pump to pump the sphygmatometer up to 200, and you will once you pump it up, you will probably see twitching in the patient arm, hand, that type of thing, some type of twitching, and that will be a sign of hypocalcemia. And the Bostic Test is where you tap at the patient cheek near their cheek. So the Bostic Test, that C, always make me think of C for cheek. Tap by that patient cheek, you will see some type of twitching in the face. It's a sign of hypocalcemia. So the Bostic Test and the Trouser sign, the Bostic sign, Trouser sign, they can be used to screen for hypocalcemia. And these are terms sometimes you will see on state board. They give you a list of foods that are high in calcium. So you want to make sure that you are looking at those foods that are high in calcium. And hypercalcemia is just informing you with hypercalcemia, it can be the result of high calcium or vitamin D intake, cancer, hyperparathyroidism, overuse of some medications. It all can contribute to hypercalcemia. And it just talks about the complications of hypercalcemia. Would somebody read the complications?
In some cases, the patient may experience kidney or urinary calculi or stones resulting from excess calcium. In more severe cases of acute hypercalcemia, the patient may experience respiratory failure caused by profound muscle weakness or heart failure caused by arrhythmias.
Mm-hmm. And if you have too much calcium, you know, one of the things we can do, we want to figure out what's causing the what's the contributing factor for hypercalcemia. If it's to the point you're taking over-the-counter supplements, we're gonna educate you need to stop. That type of thing. You eating foods that are rich in calcium, we're gonna encourage you to actually stop to get your calcium level within normal range. And it's talking about magnesium imbalance. And magnesium has an impact on our nerves as well as our cardiac muscles or whatever. And it just talks about one of the major causes of hypomagnesium is alcoholism. And for alcoholics, an individual who's an alcoholic, because one of the things I feel like alcohol make you throw up. Alcohol also works as a laxative, where you're pooping everywhere after you didn't get drunk. The next day you get diarrhea, that type of thing. You losing a lot of electrolytes. So being an alcoholic will contribute to electrolyte imbalance because you ultimately losing electrolytes from vomiting, from diarrhea, that type of thing, and the effects that alcohol has on the body. But hypomagnesium, again, it do magnesium period affects nerves as well as cardiac muscles. And it talks about the signs and symptoms of hypomagnesium are similar to hypocalcemia, including positive trousel and Bostic sign or whatever. So a patient who is experiencing hypomagnesium, you can do that trousel sign and Bostic test on them to check. So a positive trousel sign, a positive Bostic sign can be a sign of hypomagnesium as well as a sign of hypocalcemia. But most tests will only test you about the trousel sign and Bostic sign as it relates to low calcium. You need to make sure you know the normal range for magnesium. And with the with high magnesium, and tell you life no, with hypomagnesium, life-threatening arrhythmias can lead to cardiac failure and arrest. So it can stop the heart if your magnesium level is too low. It actually can stop the heart. And if your magnesium level is high, it can be a sign of kidney failure. It can be caused by kidney failure when you do have high magnesium. And high magnesium can also kind of make the body move a little slower, kind of make it your reflex a little slower, that type of thing. Hypomagnesium can kind of speed up those reflexes. And it's talking about acid-base imbalance. And this is something we discussed in Fundamentals of Nursing too. Would somebody read this paragraph, this first paragraph, please?
The acid-base paragraph.
Yes.
Okay. Acid-base imbalances are caused by a number of acute and chronic illnesses or conditions. The primary treatment for each of the imbalances is to manage the underlying cause, which corrects the imbalance. The role of the nurse is to identify patients at risk and monitor laboratory test values for significant changes. You want me to read the second one?
No, that's fine. Thank you.
Okay.
So, but I want to go over with you all again is arterial blood gases. And at this point, the electrolyte, you need to make sure you all know the normal range for the different electrolytes. You also need to make sure y'all know the normal ranges for arterial blood gases. And arterial blood gases, this is the normal ranges for blood gas that are in the arterial, that are in the arteries. The normal range for blood gases that are in the arteries. The pH, we know the normal range for pH is 7.35 to 7.45. The normal range for carbon dioxide is 32 to 45. Some book say 35 to 45. But 32 to 45 per this book, whatever this book says is true. Regardless of what I say, whatever the book says is true, because test questions will come directly from the book. The bicarb level normal is 20 to 26. When we discussed this, how to read arterial blood gases to determine if a patient is experiencing a respiratory or metabolic issue. So to determine if the patient receiving a respiratory or metabolic issue, we need to look at the carbon dioxide levels as well as the bicarbs. And whichever one is out of range, because if the bicarbs is out of range, I'm always going to think it's a metabolic issue. But if the bicarbs is within normal range and the carbon dioxide level is out of range, I'm always going to think a respiratory issue. But the pH is what will help me determine, is my patient experiencing acidosis or alkalosis? So your patient pH is 7.25. What is your patient experiencing?
Acidosis.
Correct. The patient is experiencing acidosis. So let me throw up a couple problems. I know it's 35 to 45, but I think y'all books say 32 to 45 for this particular book, but some books say different things. Let me actually look about y'all books. And HCO3 is another word for bicarbs. 22 to 26. I looked 22 to 26. Some say 22 to 28. This is 32. So whenever this is out of whack or whatever, or out of normal range, I'm always going to think a respiratory issue. When your bicarbs are out of range, I'm always going to think of metabolic issue. And anytime we are dealing with something greater than 7.45, I'm going to think of alkalosis. Anything less than 7.35 when dealing with the pH, I'm going to think acidosis. And it comes to a point where you all have to understand what contributes to these different phenomena. What's going to contribute to acidosis? What's going to contribute to alkalosis? When I'm thinking about right now in your stomach, what sits in your stomach?
Acid.
Acid. So if I go to vomiting right now, what is that going to contribute to? If I start vomiting now, it's going to contribute to acidosis or alkalosis.
Acidosis.
You say acidosis? Hello? So it's 19 students on, and it concerns me when students are not answering questions or attempting to answer questions. You want to attempt to answer questions because this is what's going to make the stuff make sense, and where you get a chance to see, am I thinking right or am I thinking wrong? So I was definitely one of those students where when it came down to it, I asked as many questions as I can, because that's what's going to help me make sense with my thinking. Am I thinking right or am I not thinking right? So if I just ask you all, in your stomach, what sits in your stomach, that's acid. You have a lot of acid that's in your stomach. If I start vomiting now, that is going to result in reduced acid. So that put me at risk for alkalosis. And I will be at risk for metabolic alkalosis because it's not affecting my respiratory system at the current time. It's affecting metabolism. So I'm at risk for metabolic acidosis, alkalosis, excuse me. So I'm going to give y'all a couple problems really quick. Patient pH is 7.53. CO2 is 39. So first, looking at the pH, is this patient experiencing acidosis or alkalosis?
Alkalosis.
Alkalosis.
Alkalosis is correct. Is the CO2 or the bicarb out of normal range?
The bicarb.
Does the patient experience a metabolic issue or a respiratory issue?
Metabolic.
Metabolic.
So based on this, we know this patient is experiencing metabolic
Alkalosis.
alkalosis. I think for y'all final for fundamentals of nursing too, I gave y'all like 1 or 2 questions on reading these ranges or whatever. And I think it's a simple question because I think I gave y'all something like what is 7.33. But moving forward, you all will get questions that look like this. The pH is this, the CO2 is this, the bicarb is this. What is this patient experiencing? What is the patient experiencing? Somebody walk us through it.
According to their pH, they will be acidosis because they are less than 7.35. Their CO is within normal range at 44. And their bicarb is at 19, which is low. So they will have a metabolic acidosis.
That's correct. So another thing I want you all to think about is right now when we breathe in, we're breathing in CO2. We're breathing in carbon dioxide when we breathe in. When we blow out, we're blowing out oxygen. Okay? So if I am hyperventilating, I'm breathing hard. I'm breathing real hard. What am I at risk for? What am I at risk for? Am I at risk for respiratory acidosis or alkalosis, or am I at risk for metabolic alkalosis or acidosis? And I want you to explain why. So be clear, CO2 is the acid. CO2 is the acid. Carbon dioxide is the acid. So right now, I'm sitting here, I'm breathing really hard. Okay? I'm breathing really hard. I'm blowing out all this acid. So my acid level is low. So if I'm breathing really hard, hyperventilating, it places me at risk for respiratory what?
Would be respiratory alkalosis.
That's correct. Yeah, that is correct. Now, if it's to a point that I have COPD, chronic obstructive pulmonary disease, and I barely can, it's like I can barely blow. I can barely blow out at all. I can't blow this stuff out. It's hard for me to barely breathe. What am I at risk for? I'm hypoventilating. I'm not hyperventilating, I'm hypoventilating. What am I at risk for?
Respiratory acidosis.
Acidosis.
I'm at risk for respiratory acidosis. Why? Why?
Because it causes the decreased respiratory
And it's causing me
it
to be,
decreasing your CO, your CO2.
and it's doing what to the CO2?
It's decreased air in your lungs.
It's causing me to retain CO2. If it's hard for me to blow CO2 out, and CO2 is a waste product. You know, our body have a lot of waste or whatever. CO2 is waste. So when I'm breathing in, I'm breathing in oxygen. When I'm blowing out CO2. So if it's difficult for me to blow out where I can't do this, I can't blow out, I'm retaining CO2. And with me retaining CO2, it is increasing my acid level. It's placing me at risk for respiratory acidosis. Okay. So you all need to make sure you read over this information. Make sure y'all reread every page. And when you are reading the information, make sure you are reading not just to say, hey, I read this information. You want to make sure that you are reading to understand the information. Do you all have any questions on a chapter at the current time?